Good good afternoon for some of us. We are, I think all of California is finally getting more rain. So we'll take it. We'll take everything we can get. But I am so excited to be here with all of you. And let's go to the next slide. I'll introduce the agenda. Well, you all know why we're here. If you're new, welcome. Our coalition is dedicated to advancing data sharing in the state. We are also really excited about the priorities for this year that all of you helped us set and our board approved, where we are focused on getting additional governance and accountability, and doing that either through you'll hear more today, legislatively, or any way that we can actually get things to stick. Two is that we are very focused on identifying funding streams, whether it's state, federal, or local funding to be able to drive the infrastructure needed for data sharing. Three, our line of sight on social services. I think this is our differentiator of where we are in California, of putting social services at the table with health services and designing our work around making sure that everyone has the information they need to make good decisions. And then finally, and this is our rallying call, is how are we also looking at this data that is moving from point to point and making it actionable, driving better quality, giving each other feedback on what we can do to be able to help each other to make that information something that's meaningful for the organizations at large. So with that, I think we'll go to the, and I just want to also take a moment. I think we haven't done this in the last couple of meetings, but let's use that chat feature. If you can please introduce yourself in the chat. I always say that this is an amazing place for us to network, not only here, but outside of these meetings as well. And it's really great for us to recognize who's here today, because we are mighty when we're together. I also am really excited to be joined by Marilee Benson today with Zen Health IT, Zen Healthcare. Marilee has been really a supporter of our work from day one. And we always are very thankful to have her insights. She's tracking and engaged and helping to lead the work at a federal level or national level around data sharing and where that intersects with our work. So we really are thankful to have Marilee joining us today. We are then going to spend just a few minutes on going through additional updates, both happening. Yes, things are still happening at the federal level. And then also here at the state too, where you can engage and where we should be monitoring action going forward. We will spend time also planning, March 19th and 20th are right around the corner. Hopefully they're marked on your calendars, but we'll spend some time on additional updates around our day at the Capitol, our dinner, and also make sure that you are registered for the CDII Summit on March 20th in Sacramento. With that, Marilee, I will hand it over to you.
Fantastic. I am very excited to be invited to be able to check in with you guys and kind of bring you up to speed with some of the things that we're working on, in my role as a member of the Care Quality Advisory Council. And then just, how I'm kind of coaching our customers who are participating in national networks on what's going on with TEFCA. 2025 is going to be the year of transition. And so that, it's really important to kind of understand what's happening at TEFCA and what the impacts and the flow down impacts are on the other networks for all that existing national network exchange. So we change slides. Perfect. So first of all, many of you may have had a chance to attend these, but the annual meetings for the national networks, Commonwealth, Alliance, eHealth Exchange, Care Equality, they all happen late in the year. So between November and December, all those annual meetings occurred. And I missed one of them. I wasn't able to go to Commonwealth this year, but I attended the rest. And the key theme was building trust through TEFCA alignment. And we're going to dive into why that was the case. But I think every single day there was at least one, if not more, sessions about trust in nationwide data exchange and this concept of TEFCA alignment. By the way, certainly eHealth Exchange and Sequoia Carry Quality sessions are available. So I just made those, I want to call that out. You can go, if you didn't get to attend, you can still see the sessions. Next slide. So when we talk about aligning with TEFCA, what does that mean, and why would we be talking about this from a national data exchange perspective? So first of all, I think that probably the most important thing to understand, if you didn't already hear about it, is that last year was the first year that we really had a major dispute happen in nationwide data exchange. It happened between two large carry quality implementers, and that had an impact on trust in the network. And it really caused everyone to sit back and say, okay, are we doing the right things in terms of understanding what treatment really means and the reciprocity requirements under treatment? And are we doing the right homework when we're onboarding new participants to the network? And so it just so happened, due to the timing of that TEFCA was kind of in the driver's seat to be able to sit back and do that, because they're creating new standard operating procedures as they operationalize and grow the network. And so they were able to look at that and go, what are we missing and what can we do differently moving forward to enhance trust across all stakeholders? And so that's where you saw the publishing of a number of either new SOPs or updated SOPs under TEFCA. And they were really focused on this whole concept of enhancing trust in the network. And that really crystallized on a couple of key ideas. So certainly the big driver for this discussion around alignment with TEFCA with the other networks is what lessons learned do we have, and how do we apply those moving forward? Also, I mentioned 2025 being a transitionary year. Epic announced, about August, I think, in 2024, that they're asking all of their customers to be fully migrated over to TEFCA-based exchange via their QHIN by the end of 2025. So you can expect to see this big adoption in 2025, moving from carry quality mediated cross-network exchange to TEFCA mediated cross-network exchange. I sometimes just call TEFCA version 2.0 of carry quality. And so, for those of us who have customers that we're supporting, or if you're participating in networks, you may be, at least for 2025, need to participate in multiple networks. Well, it's a lot easier if we're all operating under the same business rules when we're engaging in multiple network participation. And so that's a driver for alignment. And then finally, if you look at what kind of causes people who are exchanging data to have issues or concerns or disputes, a lot of it was arising from this fuzziness on the HIPAA definition of treatment and what are the business rules that we use when we're assessing new participants before we onboard them to the network. Make sure they're checking all the necessary boxes as valid participants with a treatment use case. So that's another benefit, is that we're moving from a very subjective process to a much more objective process. And I mentioned Epic in their announcement earlier in 2024, and they certainly are having a big impact. I mean, obviously they're a QHIN, so they're having influence there, but they're also influencing carry quality directly. And so an additional thing to understand that is now happened late in 2024 is Epic has taken those recently released SOPs under TEFCA and said, we're going to adopt those as a business rule under carry quality, which is allowable under the carry quality agreement. As long as you apply your business rules fairly and equally across all participants and you're not discriminatory, then you can do that. And so what they've essentially done is said, under carry quality, we're going to use this new defined version of treatment that we're going to talk about in a minute, TEFCA required treatment. We're going to use that as our business rule in Epic when we're assessing new phone book entries. So those of you who don't know, when you enroll someone new into the Carrier Quality Directory, it doesn't automatically go over to Epic. They have a review process, and then they push the directory updates to the phone book. And once it gets in the phone book, that's how Epic sites are able to make queries and respond to queries for new entries into whatever network we're talking about. And so there's a review process there. And so what they simply said is, we're going to use the TEFCA SOPs as part of our review process, even though Carrier Quality hasn't come out and made that change across all the implementers. But if you're Zen and you're a Carrier Quality implementer, and I need to make sure that my participants can access Epic under Carrier Quality, if I'm not aligning to their business rule, my customers are not going to be able to share data with Epic. So again, this is highly influential, I think, in discussions overall. The effective situation is we all need to be making sure that we understand what the rules are, we're following those, we have our evidence, and that way we aren't going to have any issues when we onboard folks to the network. Go on. All right, so thinking about alignment with TEFCA, what things do I think are aspects of some of these new TEFCA SOPs that are most likely to be adopted under the other networks, certainly this year? And while there's really three things, the two things I'm going to focus on for the discussion today. One is the new definition that TEFCA created called TEFCA required treatment, which is a more narrow definition of treatment. And this is the only version of treatment under TEFCA that requires a response, that requires reciprocity. And then secondly, we want to make sure that the people going into TEFCA meet the eligibility requirements to do this new required treatment exchange purpose. So there's homework that we have to do when we're adding people to the network participation, and that's called vetting. So there's actually a couple of TEFCA published SOPs. One defines, has this new definition of required treatment, and the other is a brand new SOP released the last quarter of last year that talks about the vetting requirements themselves. And as we change slides, I'll mention the third one is this whole concept of making on the behalf of queries, or in TEFCA world called delegation of authority. But it's complicated enough. We're just going to set that one aside. We can come back to it another time. All right, so this is actually an excerpt out of the exchange purposes SOP for TEFCA. You can see here we've got regular treatment, which is what existed before the change, before the update. And now you can see the TEFCA required treatment. It's a mouthful. And you can see that the only one that is you are required to respond to if you're making queries for treatment is this new required treatment. And there's this other version of treatment that is no longer requires reciprocity. And really the only one that matters then is this one that requires a response. So that's why, we have to really look to this new required treatment definition. And next slide. So just diving into this a little bit more detail, I mentioned that the difference is that it doesn't just point to HIPAA and say this is what treatment is. It's much more explicit than that. And so it's defining the fact that you need to be a covered entity. It's defining the kinds of licensed healthcare providers that are included. And you can see it's a pretty long list, and you can go ahead and go to the next slide because it continues on there. Obviously, we have our federal partners that are participants. And then it also does, in addition to saying who can be considered a licensed provider or eligible for this TEFCA required treatment exchange purpose, it also says who isn't. And so the big one that jumps out here is health plans. And they're specifically saying that health plans cannot be they can't act as a delegate as a QHIM participant or sub-participant. In other words, the health plan can't say I'm really a provider. And they needed to do this because if you really dig into some of the publicly available information about the dispute, this was one of the fuzzy areas that was one of the problems associated with the dispute, is like, what role do health plans play? And really what had been happening is health plans had kind of been turning themselves into a pretzel to try to meet treatment definition. And this gave TEFCA an opportunity to kind of make a decision on, how they were going to define health plan's role as it relates to the different exchange purposes under TEFCA. All right, we can keep going. And then in addition to that, it obviously TEFCA is putting a focus on the query needs to be made in connection with the intention to inform healthcare services that are being provided either synchronously or asynchronously. So it can be a virtual provider type situation. And the other thing it does is it definitely identifies some specific examples of what circumstances you might be making those required treatment queries for. And again, it calls out what isn't going to meet that standard. And I call this one out here. If you're making queries at a population level, TEFCA is explicitly saying that is not treatment or required treatment, that is healthcare operations. And I think that if you really looked under the covers and what's going on in the networks today outside of TEFCA, there's probably some population level queries happening because it's just been in a gray zone. Well, next slide. So now we're getting into the TEFCA vetting SOP that was recently released. It is designed to operationalize the vetting of new participants and particularly those using this TEFCA required exchange purpose. Its goal is to create a more objective set of requirements and that we're all kind of doing the same thing in terms of the QHINs or the folks, supporting the QHINs. And I also think, I don't know if this was by design, I hope it was, I also think it reduces the operational overhead for providers that are delivering care in more of a traditional healthcare setting. So, because if you look at we're going to dive into these vetting paths and you'll see that for traditional brick and mortar provider taking Medicare and Medicaid, it's not that onerous, the evidence that we have to gather. It can be done pretty easily. And then finally, for those providers who don't fit into kind of what I call the easy path of vetting, it does give very specific things that need to be collected, questions that need to be asked. And then in TEFCA, all of that will get submitted, that's just part of the QHIN's business practices. And then when we look at alignment from a care quality perspective, what the advisory council and the steering committee is looking at is which one of these things are reasonable for us to adopt under the care quality network, not just on a voluntary basis, but moving from well, it's great that we're all starting to do this voluntarily, but what do we actually want to require moving forward as we get further into 2025? Right? Next one. So kind of a key principle here is you've got to be one of these defined licensed providers. You've got to be a covered entity. You've got to be doing queries in the context of providing treatment health services to patients. So a lot of the vetting processes and the evidence being asked for is all focused on those elements. This aspect of the provider needing to be a covered entity, I think, is important because even though on the other networks, I know Care Quality specifically talks about covered entity, we haven't put a big focus on that. And there were some interesting conversations in December at the meetings about, well, are we leaving someone out? A good example would be, what about a private pay payer, a provider who doesn't take any insurance? They don't take Medicare, Medicaid, they don't take commercial plans. Are they falling under HIPAA or not? And so this was an interesting question, and it is a big area of conversation, and we'll have to get back to you on that because we don't know the answer, but we know that there may have accidentally been some people left out potentially, and that's an active area of conversation. And by the way, I've gotten two different answers from different QHINs. So I haven't gotten agreement on this yet, but we'll keep going. Look, next slide. And then, and from the perspective of providing healthcare services, I already kind of mentioned this, but I think it is important to note that we are including both brick and mortar providers as well as virtual providers. And we do specifically call out that in that care management and identifying care gaps is legitimate, required treatment use case for pulling data, but it needs to be done for an individual patient. And this is where we go back to this question of pulling data for a population versus a individual patient. Keep going. All right. So one of the core things to understand when we look at the TEFCA SOP and the concept of doing vetting is that the first thing we're going to do is try to quickly figure out our new participant, which path are they going to need to follow from an evidence gathering perspective. So they've identified 3 paths. You can think of them, I think of path 1 as the easy path. It's the last amount of boxes that we have to check. Gets a little bit harder with path 2. And a lot more information together under path 3. And so let's look at that a little closer on the next slide. This also is out of that the vetting SOP. I think it's probably one of the easiest things to kind of get an understanding of what they're trying to do here. And I just annotated it here a little bit on the left-hand side. So now you can see your vetting path. And across the top here, horizontally, these are the concepts that they're trying to validate. Is it a licensed healthcare provider? Are they a covered entity? Are they providing healthcare services as it relates to the treatment of a patient? And what are those interactions between the licensed provider and the patient like? So those are the questions that we're trying to answer during the vetting process. If you are a provider taking Medicare or Medicaid, participating in a government health plan, well, the assumption is the government's already validated you're a licensed provider, or you wouldn't be eligible to participate in those federal or state plans. So we can make the evidence gathering easier. All we're going to do is submit basically one type of evidence and you're done. Now, the assumption is you are a brick and mortar provider. If you go under path 1, you need to be seeing patients in a traditional office setting. The bar is higher if you are providing virtual care. And that immediately puts you in path 3. Now, for path 2, you are taking commercial plans, but not Medicare or Medicaid. You are a traditional brick and mortar type provider. And we've just got to add a little bit to the information that we're gathering through the use of Appendix 3 and Appendix 4. And then for the path 3, there's some, once again, more questions to answer, basically. So we'll keep going because we're diving into this in a little bit more detail, but that's a good overview. So you saw that there was type 1 evidence and type 2 evidence. I think about this as, how many of you have ever filled out an I-9? I'm sure all of us have. And if you think about an I-9, you have these list of documents that you have to provide, and they're divided into a couple of different types. And so this is the same concept. And so for type 1 evidence, which are those providers taking Medicare or Medicaid, you can simply provide, and if you look at the SOP, it gives you a link to all of the CMS sites that you can go to, find the provider organization, take a screenshot of it, or provide the link to the person that's onboarding you to the network. That will be the process. It's very straightforward, and they're literally giving you all the sites that you could be using. For type 2 evidence, which comes into play for paths 2 or paths 3, we're adding and layering in some additional information. So first, we want to make sure we validate they're a licensed provider. So there's a couple of things we can do. We can do the NPPES database, which is the big registry of NPI numbers. You could do a copy of malpractice certificate coverage. They've got some other examples, in the SOP, but we have to provide under path 2 or path 3, evidence that they are a licensed provider. And then we also have to have evidence that they're a covered entity. And so that would be, if you're not doing Medicare or Medicaid, that would be, provide the commercial insurance evidence, right? They're listed under United Healthcare or Aetna or Cigna or whatever. They've got some other documents that would be acceptable if that doesn't work. But the whole point there is just to demonstrate that they're participating with commercial insurance. And then when we get into path 2 and 3, there are some additional requirements. So we'll move on. So Appendix 3 is required for paths 2 and paths 3. And these are the questions, the additional information that they're asking for those two paths. Explain the ways in which the provider provides healthcare services to patients, and how are they going to make queries? So you're going to describe how does that provider interact with the patient, and it's pretty straightforward if you're a brick and mortar provider. If you are a virtual care provider, it gets more interesting, and therefore we need to provide a little bit more information. And we're also going to talk about when we make queries, how are those queries made? Are they done just real time, sitting in front of your EMR or the system that you're logged into? Are they triggered through some automatic mechanism? Are you doing an appointment query, which is fine? Like you could do a batch of appointments. So to prefetch data, that's perfectly acceptable. That's not considered a population-based query, but they want to understand that as part of the vetting requirements. And that's just making sure that, the licensed provider is providing healthcare services to patients. All right, we'll go on to the next one. Under Appendix 4, again, applicable to both paths 2 and 3, at least in terms of this requirement called Exhibit A. So in addition to the two questions that we just looked at under Appendix 3, we also have to do a patient interaction attestation, and they were kind enough to give us the language. So all you have to do is copy and paste it out of the SOP, have your provider put it on their letterhead, submit it to your QHIN, you're good. And then, of course, if we adopt something like this in Care Equality, if we should, then we'll need to change the language to not reference TEFCA. For our Zen customers that we're onboarding to Care Equality, we're going to use this concept of the patient interaction attestation for people that qualify for needing that. And we're just changing the language to reflect the Care Equality Network instead of TEFCA.
Marilee, I'm just going to give you a heads up with timing so that we can get to questions.
Awesome. I think this is literally the last slide.
I think so. Yeah, look at
that. So the last one there is, if we go back one slide, there is some additional questions for path 3 that is listed there. Yeah, there you go. You have 2 additional questions to answer. And this is particularly important. Again, thinking of path 3 as for the most part covering those virtual care providers, telehealth, you can think of lots of use cases where there's a lot of telehealth and virtual care being provided. And so we're just getting more additional information on how those providers interact with those patients during those in that kind of setting. And that's it. We are 2 questions.
Well, Marilee, thank you so much. And I know I've been monitoring the chat. We definitely have some questions. I think most of the intersection is between the data exchange framework and TEFCA, new TEFCA. Do you want to just start there, just of your observation, and then we can go on some specific questions?
And I'm sorry, are you talking about specifically?
Just the data exchange framework includes optional participants, including CBOs that may or may not be HIPAA covered entities. And, what is your thought there?
Well, I think it's one of the things that California is going to have to look at in the same way that we're looking at it at Care Equality, right? That Care Equality needs to decide, and Commonwealth's doing this, and eHealth Exchange is doing it. Looking at TEFCA, talking it through, and deciding how those and if those requirements can apply, or if the governance is simply different and it needs to be different. And that's just a decision that's going to have to
It's
be
going
made.
through an alignment exercise as you just described and
Right.
then deciding what's right. But I think just having these tools in our tool belt of being able to have additional verification as part of validating your trading partners is something we can learn from. There's a question about Kaiser. You know, Kaiser clearly an Epic user and both a brick and mortar as well as a health plan. Like, has there been some discussions there?
So the discussions that we've had about what happens when a health plan, certainly, if they are hiring physicians and delivering healthcare services, then they are kind of living in they are wearing two hats. And so but it is hard because that's pretty obvious. I have a hospital, I got clinics, I may be a health plan, but I'm delivering healthcare services directly. I think no one intends to make those kind of folks not eligible for making treatment-based queries. Where it starts to get interesting is when you have a health plan who, let's say, make some technology available to their providers that are participating in a certain, managed care plan, and they're sponsoring that technology, and then they're going to initiate queries on the behalf of those providers. Well, are they going to have access to that data that they're querying through the networks? Is it really a treatment use case, or is it really the payer getting data that they couldn't get otherwise that they're going to use for other purposes that are not purely treatment? And those are really the use cases where TEFCA wanted to be a little bit more definitive about, as I understand it. And I'm not in those QHIN conversations. So, it might be great to get someone like Liz from Commonwealth to talk to the group, where she actually, brings the QHIN direct voice. But, as part of my role in the Carrier Quality Advisory Council, there's multiple QHINs that are participating in on carrier quality also, and this is what we understand.
Yeah. We should probably maybe have a whole other conversation about the impact of population health, but I'll leave that for later. I think these are really super questions. One is how does the required treatment limitation align with or contradict with our information blocking provisions? Do you have some thoughts there?
Well, yes, I think that the danger of having a more narrow definition of treatment is just that. I think that the good news is, it even TEFCA the TEFCA participants or the QHINs will tell you it's iterative. And I know Epic's specific opinion is let's narrow it down and then open it up. So I think part of the benefit of having a required treatment and a treatment is that some exchange can happen voluntarily under treatment. And that then provides an opportunity for the council, the governance council of TEFCA, to go, oh, here's a use case that is left out of required treatment. Let's define that and roll it in. So I think that it's important to think of this as a process that's going to evolve over time.
That's a really good point.
Yeah.
And what about HIEs? We have our QHINs in California. We have QHIOs. We also have several other intermediaries that are not QHIOs. What are your thoughts there?
Well, I think that for HIEs that have been participating, especially in things like eHealth Exchange, it is an interesting question when they roll up to TEFCA, because it's a lot of work. I mean, they look at how many participants they have. And so if you look at the overhead associated for a large statewide HIE to gather evidence on all of these entities, that's huge. I am hopeful that, to me, that's an area that needs more input, because in the same way that they make that path one vetting so much easier for people participating in Medicare and Medicaid, I don't understand why they wouldn't, in the future, consider the same level of governance as happening at an HIE level, and maybe those people just all flow to the easy path. But we know, and we also know that Kanza is a QHIN, and Kanza, of course, works a lot with HIEs and operates HIEs. So I actually need to just pull them aside and have a conversation with Laura, because who's the executive director, because I think that's an excellent question. And I am concerned that we're putting too much of a burden on HIEs when it comes to TEFCA vetting requirements.
And I'm going to fit in a couple more. Really great question, Seth. Great to see you here about 42 CFR Part 2. So that in California, some experience is that that information is protected and not shared by the QHIOs. How is TEFCA dealing with that, and what kind of consent is required?
I have not seen any written SOPs on that, which means I don't know. I
Okay.
know that there's language generally that says if the data is not legally allowable to be shared, and this is the same way it is in carry quality today, you are not mandated to it's they're defaulting on the side of not sharing for that protected data.
Mm-hmm.
But as far as I'm aware, and they may have had some conversations I've not been into, they're not they haven't reached the point where they're trying to address that, other than simply saying that, you can continue to protect data that isn't legally allowable to be shared.
And Olivia, did you have a question as well that I think you had for Marilee? Oops, you're on mute.
Thank you. I had one question that I asked Marilee during her office hours a few weeks back, but I think it'd be interesting for the rest of the group. We learned before about how uh, organizations can partially align with TEFCA. And could you kind of explain the implications of that with just partial alignment versus full alignment with TEFCA?
Well, I think if you're going to if you're going to join TEFCA, it's all in, right? I don't think there are exceptions. I think that you will see people like Carry Quality partially align with TEFCA, because there may just be things in the governance of Carry Quality that just doesn't fit. Right. And so again, that's just this whole idea where Commonwealth, Carry Quality, eHealth Exchange within their own networks outside of the scope of TEFCA will align where they can, and where their own agreements or where their own governance model simply can't get to a consensus that that's what they want to do, then they'll just take lessons learned, they'll apply what they think they can, but they won't necessarily implement everything. I mean, just the fact that there's only what, 7 QHINs now. We don't expect there ever to be as many QHINs as there are carry quality implementers, for example. So, there's some just logistical things. It's easier for a small number of QHINs to manage than, this huge, 30 or 40 or 50 different entities involved, that makes it much harder.
And I'm going to try to squeeze in one more, which is, are there any dispute resolution kind of learnings that you've seen across the different entities that we might be able to learn from, if you can point us there, or maybe we pick your brain on that again at a later time.
Yeah. Well, I think the big lesson is, number one, have written dispute processes in
Right.
place. It is absolutely vital. It is difficult. And even though Carry Quality did have a dispute policy, in place, thank heavens, but as part of going through that process, they certainly identified gaps, and they'll be going through and doing another iteration and maturing those. And, hopefully they'll share those, and then everyone else can kind of learn from that. But you definitely have to have a way of formally managing it. And then I think the other lesson learned from Carry Quality is they want to have an interim step that Carry Quality didn't have. They kind of went from 0 to 100. There was no interim process to try to take a disagreement and get on top of it and manage it before it became a formal dispute.
Right. Well, there's some other questions here in the chat, and Marilee, I don't know if you have some time, but you might be able to address them here asynchronously, or we can
I'll
follow
look
up
at
with
those
you.
while you're moving on.
Yeah, and then we can also follow up with you. And then if everybody could just give Marilee a little bit of some thumbs up for joining us today and spending your time with us. And Marilee, maybe on our office hours too, there's so much going on at the TEFCA. I would offer that you could join our office hours. And I know you have office hours, but the more we can learn from each other, the better, in my personal humble opinion. So again, thank you for being here and joining us today.
really appreciate the opportunity and happy to do all those things.
Okay, we will do so. All right, let's Olivia, let's move on to our agenda, and we will do our best to talk fast, everyone. You know we can.
Sounds good. I'll hop in here to get us through some quick federal and state policy updates. First one we think we saw come in our inboxes the other day is that USCDI, the draft version 6, is now available for public comment through April 14th. And it does include 6 proposed data elements. And for some background, the USCDI, United States Core Data for Interoperability, is a standardized set of both data classes and specific data elements that are designed to help enable nationwide interoperable health information exchange. A few of these 6 proposed data elements include a care plan data element, family health history under the problem data class, date of onset for the problem data class, and then finally, unique device identifier for medical devices, facility address, and also portable medical and portable medical orders. Related for the DXF, the CDII has finalized an amendment to the data elements fee exchange policy and procedure to automatically align the data exchange framework with the US CDI version. That is required by the ASTP Health IT Certification Program, with this PMP going into effect on January 1st, 2026. For a little bit of context, the DXF currently requires version 2. And when this PMP goes live, which also aligns with when ASTP is updating their baseline standard as well, version 3 will then be the baseline standard for the DXF as well under federal requirements. And I believe Remy is popping links in the chat. And then one final piece here on the DXF is that the Technical Advisory Subcommittee has applications open, and we would love to see C4BH representation there. So please apply. Organized the group last year, and they're going to be hosting 4 focus groups to advise CDII on identity management, consent management, social services, information exchange, and then finally event notification and event-based exchange. So please apply. It's a super short application, and I think many of us have expertise that would be of value there. All right, getting into our state tracking. I don't think we'll have time today to really go through the list. Promise we will make sure we do that before our upcoming day at the Capitol. But a key date to keep on everyone's calendars is that February 21st is the deadline for bills to be introduced. So I'm not sure how many we currently have on our tracker, but you will see it is a lot. I think at least 15, maybe 20, with many more rolling through. A few that we wanted to bring, or I guess one thing that we wanted to bring to everyone's attention is that similar to AI and how we began tracking AI bills last year, we're moving forward with that again this year. We've also been seeing a lot of bills related to prior authorization. So we've been adding that to our list for tracking. And would love to hear from the coalition if that aligns with your interests, or if there are other types of bills that have been coming out that we should also be adding to our tracking list, in addition to AI, prior authorization, and then general data sharing bills. And Timmy, if I could hand it over to you to talk about our upcoming office hours.
Yes, so I'm so glad we have the office hours now scheduled as part of our programming. We were really making use of them. And we've had several of our participants and coalition advisors ask us to really focus on housing as a way to start with getting real about use cases and data sharing among and between social services and health services. And public health as well. So I would welcome you all to join. This will be more of a listening session and getting started. We did have a think tank that we hosted with the California Healthcare Foundation and CDII last fall that some of you attended. We will be building on that momentum, but please put this date and time on your calendar, and I'm hopeful that we'll be able to keep the discussion going all year long, and being able to collect what are those bright spots, where are we having some real progress being made in our communities, and also being able to identify where there might be some barriers that are similar barriers. And if we could tackle that one, we can tackle it across several communities. So that's really where we're starting. And luckily, last year, as part of our sandbox and our design studio work, we did complete a housing use case that we can use as a way to get the conversation started, because we learned so much. And I think what we can do is, based on what we designed in that one community, think about where and how that might actually fit in other communities. What did we learn across different payers and stakeholders, payers, providers, other stakeholders, and then what can we also relay to the state on what can be done to be able to ease some of the burden that we were able to really map out. It's pretty considerable. So please come.
And I'll note too that we threw a little bit of a pre-read in the chat for folks.
Thank you. Thank you. And here we go. We, again, just if it's not on your calendar, we are putting an all-out push. You know, what happened to us this week is maybe shouldn't have been so caught off guard, but February is a short month. So instead of us being, 6 weeks away from the event, we are 5 weeks away and barreling through. So please make your reservations. We do have if you look up on that website, we have a hotel block. Join us. It's going to be fun. And if you need a scholarship, let us know. Just reach out. We'd be happy to work with you. And then the next slide is the summit. Well-timed to have our dinner the night before, and then also really welcome all of you to sign up for the summit. I would say do it soon. I've said that now or the last couple of weeks, but we're getting to that point where we're going to have to limit our attendance. So if you haven't already, please sign up for the summit, ask your colleagues, bring a +1. It's going to be a great discussion.
All right, and I think just a final few pieces to take us out. Here's what we've been reading. Check out our newsletter. I hope everyone enjoyed the new layout that we have, a little bit more of an updated feel. One thing I'll note for our newsletter is that we want to really make sure that we're highlighting our coalition partners and all the great work that you're doing. So if any news is coming out about your work, well, of course, we're trying to keep an eye out, but please feel free to send it to us in advance. We'd love to help feature your organization in our newsletter. The one story that we highlighted this week was around the CHCF's regional survey results around CalAIM experiences. And there was some really interesting county by county information in there on data sharing insights. The reports are broken down into five regions: the Bay Area, Central Coast, Central Valley, Northern California, and also Southern California. And overall, they found that methods are very much varying by region. But it was an interesting finding that information is least frequently being obtained through an HIE or a CIE. And there are calls for the need for improvements in data completeness, accuracy, and timeliness. And then we also have a couple other industry updates that we made sure to highlight in the newsletter as well. A few upcoming webinars and events. AHIMA is having an interesting webinar coming up on how artificial intelligence can enhance the use of SCOH data. C4BH will also be at Vive in just a couple weeks, or not even this week.
It'll be Sunday. I'm heading out there on Sunday. If anybody's going to be there, I was just saying, Marilee, it sounds like we can hopefully connect, but if others are going to be in Nashville on Sunday, Monday, Tuesday, please let us know. We'd love to connect.
I think the C4BH team will also be at CPCI, so we look forward to connecting with people there. And then, of course, make sure you have on your calendars, and please, get your tickets soon for our Day at the Capitol, our annual dinner, and then also the Cal HHS 2025 Annual California DXF Summit. And I know I'll be attending the RCMA AI Healthcare Conference, which was a great event last year, and very excited for it coming up this year.
Quick question, Olivia, about our office hours. Is that on everybody's calendars as a recurring meeting, or are we doing that ad hoc every month?
They're still ad hoc every month. Maybe moving forward, we can try to get a standard time set up.
Yeah, we should do that.
But currently ad hoc.
So Jonathan,
then-
just follow up with us if you're not getting that invite. We'd love to see you there. All right, we did it. Any other announcements?
I think that's it from us.
Anybody on the call want to make an announcement? All right, well, thank you, everybody. Thanks for joining us today, and we are looking forward to seeing you in 2 weeks and hopefully see you in person up in Sacramento. So again, thank you, Marilee. Appreciate you. Take care.
Thank you, everyone.